and welcome to a presentation on CT findings of common liver lesions. Some of the main ideas to take away from this presentation include that the appearance of a liver lesion is dependent upon the attenuation difference between that of the lesion and that of the normal liver. It's also important to acknowledge that few tumors contain calcifications, fat, hemorrhage, or cystic components, and we'll also discuss the importance of contrast. First, let's talk about the dual blood supply of the liver. It is important to note that the normal liver parenchyma receives most of its blood supply from the portal vein. However, liver tumors typically have a proportionately greater blood supply from the hepatic artery. This is important in utilizing the various phases of contrast to assess lesions. As you can see here, the liver and the rest of the abdomen appear slightly different depending on which phase of contrast imaging is obtained during. The arterial phase is divided into early and late arterial phases. During the early phase, we have better visualization of the arteries and we notice irregular enhancement of the liver. During the late phase, we see partial portal vein enhancement. Optimal enhancement of hypervascular tumors occurs at 35 seconds from contrast injection. This is the time needed for the contrast to get from the peripheral vein to the hepatic artery and to diffuse into the liver lesion. The portal venous phase, or the hepatic phase, refers to the time interval during which imaging is obtained when the contrast is in the portal vein. During the portal venous phase, we notice uniform enhancement of the liver, which is especially advantageous in detecting hypovascular lesions. It's important that we understand that hypoenhancing lesions, such as most METs, stand out better against the liver in this phase because the liver strongly and homogeneously enhances during the portal venous phase. Hypovascular metastases are usually seen as hypodense lesions in the late portal venous phase. The delayed phase is obtained when contrast is washing out of the liver. This is usually performed 3 to 4 minutes after injection of contrast. During the delayed phase, we notice a decrease in density of the liver. In regard to this stage of contrast enhancement, it is important to learn about and define the term washout, which is a temporal reduction in enhancement relative to surrounding liver from earlier to a later phase. We'll now focus on talking individually about common liver lesions. First, we'll talk about hemangiomas, which are venous malformations of the liver. They're some of the most common benign vascular liver lesions, and they're often found incidentally, as most patients are asymptomatic. It's important to differentiate hemangiomas from malignancies, as they may share some similar characteristics. Hemangiomas during the non-contrast phase are often hypoattenuating relative to liver parenchyma. During the late arterial phase, they typically show discontinuous nodular peripheral enhancement. During the portal venous phase, they demonstrate progressive peripheral enhancement with more centripetal fill-in. During the delayed phase of imaging, they further irregularly fill in and therefore are iso or hyperattenuating to liver parenchyma. As you can see here, on arterial phase imaging, there is nodular discontinuous peripheral enhancement. Enhancement increases on the portal venous phase, and the lesion progressively fills in or enhances centrally on delayed phase imaging. Adenomas are benign hormone-associated liver tumors with a high risk for hemorrhage. Hepatic adenomas are traditionally considered the most frequent hepatic tumor in young women on the oral contraceptive pill. Other risk factors for adenomas include obesity and metabolic syndrome. They're usually asymptomatic until spontaneous rupture and are commonly seen at the subscapular location in the right lobe of the liver. Adenomas demonstrate variable attenuation dependent on their specific features. For example, fresh hemorrhage would appear as hyperattenuating, whereas fat content within the lesion would appear as hypoattenuating. Generally, adenomas are isoattenuating and are well marginated. If calcifications are found due to old hemorrhage, they would appear as hyperdense spots. With contrast, they demonstrate isodensity on portal venous and delayed phase imaging. On arterial phase imaging, there is a solid nodular enhancement that is greater than the background liver parenchyma. However, when we go through the portal venous and delayed phase imaging, the lesion is nearly invisible. Focal nodular hyperplasia is a regenerative mass lesion of the liver. It is the second most common benign liver lesion and has a strong female predilection. It is found either due to mass effect or incidentally. It is rarely complicated by spontaneous rupture and hemorrhage, unlike hepatic adenomas. The typical and atypical variants of focal nodular hyperplasia are distinguished based on the presence or absence of a central scar. Focal nodular hyperplasias are ideally evaluated on a multi-phase liver CT. On a non-contrast series, they are usually hypo or iso-attenuating. They demonstrate bright homogeneous arterial contrast enhancement. The central scar, however, remains hypo-attenuating. During the portal venous phase, they demonstrate hypo or iso-attenuation to the liver and are poorly visualized in many studies. On arterial phase imaging, there is solid nodular enhancement greater than the background liver parenchyma. There is also a possible small area of hypoattenuation centrally, which may represent a characteristic central scar. This lesion is nearly iso-attenuating to liver on portal venous imaging, and the central area of hypoattenuation is no longer apparent. Hepatocellular carcinoma is the most common primary malignancy of the liver. It is the fifth most common cancer in the world and the third most common cause of cancer-related death after lung and stomach cancer. It has a variable presentation, with clinical symptoms mostly being considered in the setting of risk factors. The pathophysiology of hepatocellular carcinoma is thought to be related to repeated cycles of necrosis and regeneration. There are three main types of hepatocellular carcinoma. The first is massive or focal, which usually has necrosis, fat, and/or calcification. Nodular or multifocal, which usually includes multiple masses of variable attenuation. They may also have central necrosis. The third is infiltrative or diffuse. Recall from earlier in our presentation that liver tumors receive a disproportionately greater amount of blood from branches of the hepatic artery. Therefore, hepatocellular carcinomas have a characteristic enhancement pattern, which includes early arterial enhancement with early washout. In this example of hepatocellular carcinoma, notice on arterial phase imaging there is solid nodular enhancement greater than the background liver parenchyma. However, on portal venous and delayed phase imaging, notice how the lesion demonstrates slightly lower attenuation than the background liver parenchyma. This is because the lesion washes out and demonstrates pseudocapsular enhancement on portal venous and delayed phase images. Cholangiocarcinomas are malignant epithelial tumors arising from the biliary tree. Some shared characteristics of the prominent risk factors for cholangiocarcinoma include biostasis and chronic inflammation of biliary epithelium. Patients may present with painless jaundice. Mass-forming cholangiocarcinomas on non-contrast imaging are homogeneously weakly attenuating. With contrast, they show heterogeneously weak peripheral enhancement with gradually increasing enhancement toward the center of the lesion. Periductal infiltrating tumors present as regions of duct wall thickening or of the periductal parenchyma. The most important characteristic to note is the narrowed caliber of the involved duct. These tumors are most common at the hepatic hilum. Intraductal tumors present as alterations in duct caliber. On arterial phase imaging, notice that the right hepatic lobe mass is hypoattenuating, with areas of linear internal and peripheral enhancement. This lesion has a similar appearance on the portal venous phase. On the delayed phase, however, we notice that there is increased irregular peripheral and internal enhancement. Also notice that the delayed phase here is 15 minutes, as a longer delay is used for cholangiocarcinomas than for other tumors. Next, we'll talk about metastases. Metastases are much more common than primary liver malignancies, and their incidence increases with age. They're clinically usually asymptomatic, but may produce symptoms in context of increased metastatic burden. Some common sites of primary malignancies that metastasize to the liver are the GI tract, breast, lung, and pancreas. Some radiographic features of metastases include hypoattenuation on non-contrast imaging. On contrast-enhanced imaging, they often enhance less than the surrounding liver parenchyma. We may also notice peripheral enhancement on the portal venous phase. Washout may be seen in the portal venous phase, which can be useful in distinguishing metastases from hemangiomas. Many hepatic metastases are hypoattenuating to the liver parenchyma on the portal venous phase. A small subset of metastases demonstrate avid arterial phase enhancement. In this patient with a neuroendocrine tumor, note how much easier it is to see numerous enhancing lesions on the arterial phase when compared to the portal venous phase. The final lesion we'll discuss is an abscess. Abscesses are localized collections of necrotic inflammatory tissue caused by microbial agents. In developed countries, they're usually a result of bacterial infections. In developing countries, they're usually caused by parasitic infections. A typical patient presentation may include symptoms such as right upper quadrant pain, fever, and jaundice. The route leading to abscess formation may be an important consideration clinically, with common routes including hematogenous spread, biliary spread, and direct inoculation. Abscesses have a variable appearance on CT. They generally appear as peripherally enhancing, centrally hypoattenuating lesions. One imaging characteristic to be aware of is the double target sign. It is best seen on contrast-enhanced CT scans, in which a central low attenuation lesion is surrounded by a high attenuation inner rim and a low attenuation outer ring. In this example of a hepatic abscess, notice the large multiloculated collection in the left hepatic lobe with peripheral enhancement and internal septations similar in attenuation to the liver parenchyma on portal venous phase imaging. There is also a large subscapular collection, with sites of communication to the abscess best visualized on the coronal image. To conclude, it is important to emphasize that CT is often helpful in evaluation of a variety of liver lesions, and that multi-phase imaging after contrast administration can help aid detection and classification of lesions.